Hello, everybody, and welcome back to episode 19 of CCA's Medical Minute podcast. We are going to talk about, do our second round of chemo discussion today, prompted by our new friend Tina, who asked about some of the long-term effects of chemotherapy and radiation. So we're going to do that in just a minute. But first, a couple announcements. So our little fledgling podcast is now sponsored by the 22,000 good folks at Kroger Health.
Thank you, Kroger Health.
Which is pretty awesome. I didn't know this until today. They have 2,300 pharmacies around the country, 200 in-store clinics, and I'm going to give you a chance to start out the first explanation today. They have 11 specialty pharmacies. So what is a specialty pharmacy? How does that differ from other pharmacies, Jill?
So a specialty pharmacy is where you are going to get very specialized medications. You're not going to get your run-of-the-mill blood pressure medicine or insulin from a specialty pharmacy. But those medications that are astronomically expensive, most pharmacies are not going to keep those on their shelf. So there are... and each insurance company will tend to have them. Some of the hospital systems will have their own specialty pharmacies. But it's just a local reposit for those more treatment-specific, disease-specific drugs that tend to be a little bit more costly.
Like my $11,000 a month drugs.
I actually had a patient bring in a bottle of Ibrance, which is used for breast cancer.
Okay.
And she brought it in, and she handed it to me. And she said, "Have you ever wondered what it felt like to hold $12,000?"
I know.
Wow.
It's crazy.
And I looked at it, and I kind of turned it over, and I shook it a little bit, and
That's
I was
what it
thinking,
feels like.
I was thinking, like, this should come with some bling on it or something. like maybe it should light up when you open it. Or
Right.
And we should say that for some of the specialty medications, there are different programs out there. So thankfully, a lot of the
Yes.
people that need them
True.
are not having to pay the $11,000.
Yes.
But again, that is the big price tag there
Yep.
on some of those kind of drugs.
Yep.
Yes, and that price tag, when patients get that explanation of benefits, it can be a little breathtaking.
More than breathtaking, jarring, to say
Yes.
the least. Yeah.
And by contrast, do you guys remember when they introduced the $4 prescription?
Yes.
I do.
There's still people standing in line because of that $4 prescription.
Wow.
So for someone like me, Mr. Short-Term Attention Span,
Yeah.
Diana goes to the pharmacy for us
Yes.
because I just can't deal with it. But anyway,
We digress.
yes, we digress. So I'm not going to be my normal kind of loose guy today because Diana my wife has made me feel very self-conscious. So
Okay, what did she tell you?
she gave me lots of good feedback this weekend, lots of very positive feedback, but she told me that I slouch.
Okay, then are you sitting
Are
up
you
straight?
are you sitting up
I'm
straight?
trying to sit up straight.
doing
I
good,
don't know,
yeah.
but Sherry's so tall that it
Yeah.
looks like I'm slouching anyway. So
I'm not that tall. I'm just 5'9".
well, you look taller than that.
Okay. Well, I also sit up straight.
All right.
That helps.
It does.
All right.
Okay.
All right. So Kroger Health, by the way, also is the presenting sponsor of our golf outing, which we just announced today, August 29th at Makatiwa Country Club with Anthony Munoz. Not that that matters, but I'll go ahead and throw it out. And so let's go ahead and get into Tina's question. So thankfully, we have someone sitting to my right who I'm not thankful that she's a 2.5-year cancer survivor, but in terms of answering these questions about the long-term effect of chemo, she's the perfect person to talk to because she's dealing with some of those things now. So Sherry, can you take us through some of I know you made a brief mention of them before, but can you take us through some of the effects that you feel from chemo?
Sure can. And it's 2.5 years later, and I'm still dealing with some neuropathy, some from nerve damage. I feel it somewhat in my tips of my fingers and also sometimes in my foot or my feet. I'm dealing with chemo brain every day almost. There's times when I can remember things, and then I all of a sudden can't remember it, but then it does come back. So it's like that foggy brain in and out. There's also some muscle pains. Inexplainable and unexplainable, should I say, at times. It's like, I don't know why my back is aching or my legs are a little bit more fatigued. And speaking of fatigue as well. Sometimes I'm a little more, tired at the end of the day, earlier than I would be on other days. Sometimes I feel like I need to go to bed, earlier. Then it's just sometimes I just feel like I am a little bit lethargic.
Yeah.
So, and this is 2.5 years out, but I'm also still taking some breast cancer medication. So that may contribute to some of what I'm feeling. But there are lots of folks out there that have had, Jill, and you could speak to this, have had some long-term effects from chemotherapy as well as radiation because of the differences in the drugs from now and then back then.
Right. So a lot of what we look for from a clinical standpoint is the fact that some of the chemotherapies that we use to treat the cancer can actually go on later in life to cause a second cancer. So just because we treat the cancer up front doesn't mean that monitoring the patient isn't ongoing, and it's not necessarily just for what they were originally diagnosed with.
Yeah.
In addition to that, we were talking about earlier today how much radiation has changed. If you got radiation 25 years ago compared to what radiation is now, it is much more pinpoint, much more specific targeted locations versus 25 years ago, patients would get radiation and it was in bigger fields, bigger blocks.
So they have intensity modulated therapies now, radiation, where they're just zooming right in on the particular area. And that helps. Some people get that, some people.
It does. And the impact that it has, and people are like, well, why does that make such a big difference? Well, when you start looking at the amount of healthy tissue that is impacted by radiation, from treatments that were from years and years ago versus more specific targeted spots that less healthy tissue is impacted. A lot of the lymphoma patients, the field of radiation would be so broad that they would later on develop cardiac issues and have to have valve replacements or open heart surgery. Like, there are things that developed strictly because of the treatment that they had.
And so, Steve, you're still having radiation treatments now. Are you experiencing
I've been really, really lucky because, I know oftentimes you read about some of the bad side effects of radiation. And maybe everybody's body tolerates it a little bit differently, but I've been really fortunate to not really think that at least if I have side effects from that, I don't really notice them, I don't think. But and we talked about this before. I think there's one misconception that you just kind of addressed just by the fact that the treatments are less
invasive.
Toxic, invasive. I'm not sure what word I was going to use, but I know when I first had my first round of treatments, it was 33 radiation treatments, and I thought I could never have radiation again, and that's not. It's actually not true. It's actually a good news story because if you have a recurrence, there are times where you can be retreated with radiation because it is so precise now.
Yeah.
And it does. It all has to do with location.
Yeah.
You are limited to the amount of radiation that specific spots can get. And bone is very sensitive to radiation. And it's funny because we'll have a patient that will have a spot treated with radiation. And if they have a local recurrence in that same area, they're like, why can the radiation worked before, can we not do that again?
Yeah.
The bone can actually completely disintegrate if it has had too much radiation to it.
Is that why I'm still getting the DEXA scans for my bone?
So you're getting the DEXA scans for your bones because of the blocking of the hormones.
Okay.
And so when you have lower levels of estrogen, it makes you at higher risk for osteoporosis. Same thing in men who have the androgen blockade for prostate cancer. Yep. You block those hormones and it decreases the density of those bones, which puts you at higher risk for fracture.
I'm happy to say I just had my DEXA scan about a week ago and my bones are doing good.
Nice.
Good.
Am I doing
Very, very
Good,
nice.
good.
Bones are doing good. I also had the heart echo, and that's another thing that
Yes.
if you're getting radiation or even chemotherapy, sometimes the heart echoes are ordered.
Yes. Well, and a lot of the breast cancer patients will have the HER2 amplification. And so if they were being treated as an early stage, they go on the Herceptin-like drugs, those HER2 blocking drugs for a certain amount of time. And those drugs are known to cause heart failure. And so they get periodic echoes or MUGA scans as they are going through treatment. For our metastatic breast cancer patients who continue on that therapy and use it long term to control their disease, they have to have those periodic echoes throughout the duration of the treatment.
And it sounds like this is all, really just so much, but these processes and these treatments, the benefits are outweighing the
Right.
risks.
Right.
So you
Yeah.
have to oftentimes you have to get this in order to take care of the disease, but then you have to manage the risks and
Yep.
see what could be happening later down the
Right.
line.
And the percentage of people who get those secondary malignancies is low. It's not zero, but it's low. And so if you go into treatment for your cancer with the fear of, well, if I do this treatment, I'm going to get cancer down the road.
Yeah.
Well, that's all well and good, but my goal is to get you down the road.
That's
Yeah.
true.
And if we don't treat it now, then this cancer is going to become a problem for
And
you.
let's say to Tina or to anyone else that's out there, if you are 10, 15, 20 years out and you're still experiencing a lot of these side effects and they're very harsh, you really need to take that back to your physician because now they have so many other things out there that can help you to manage that or to make it perhaps a little better.
And it doesn't necessarily have to be medication related. There
true.
are so many survivorship programs that focus on living past cancer treatment and managing what happened with your body while you were going through cancer treatment.
Yes.
We've talked about different alternative medicines and acupuncture being used to help with the neuropathy. There's all kinds of different programs because we're identifying that people are living longer because the treatment options for cancer are better and people are living.
And we cannot forget, we talk about this all the time. Steve likes to make jokes about it. Water. Drinking plenty of water, also getting some form of exercise.
Not
and
just
your
water, Kroger water.
Oh, yeah.
Getting
That's
some form of exercise as well as your diet, the nutrition. You can find foods that can help you to combat some of the side effects. And again, you definitely can get through these things, but sometimes you need a little extra help.
Yep.
Right.
Yep. All right. I'm going to ask a dumb question, and then we'll wrap, and then we'll decide whether we do another episode or not. But because I often hear, because as you know, my wife is a 6-year breast cancer survivor, and so I often hear about the chemo brain. So here's the stupid question: is since chemo is a systemic treatment and it's kind of indiscriminate in how it targets cells, is it possible that that's due? I mean, like literally, or do brain cells get wiped out as a result of chemo?
So there is something called the blood-brain barrier.
Yeah.
And chemotherapy drugs do not cross, most of them do not cross the blood-brain barrier.
So it's not an excuse then.
So that's
Yeah.
not
So what
an
you're saying
excuse.
is that the brain fog is temporary, even though it may come and go. It's
And
not permanent.
It's not permanent, and
Thank
it's
you.
not an actual, it's a global impact, not a brain
Okay.
dysfunction.
Okay.
Very
All right.
good. Thank you.
Yes, yes.
I do other things that kill blood cells or brain cells, so pretty much every night. So anyway, okay, so we'll go ahead and wrap this one up for now. Thank you guys for another great episode. And
Let me jump in.
Yes.
Tina, if we answered all of your questions, great. Just let us know. But if we didn't, and there is anything else, or if any of our other viewers have any questions regarding specific long-term effects or something that you'd like us specifically to speak on, please, please, please comment on our YouTube videos, on any of our social media pages. We have Chris, who monitors those very closely and keeps us posted whenever comments are made. And so we're trying to make sure that everything that we're doing is very intentional and that it's meeting the need of our viewers.
Yep.
So
Yep.
please comment, please ask your questions so that we can answer your questions for you.
Sounds good. And to the 22,000 employees of Kroger Health, please subscribe to our podcast.
Please.
Thanks, everybody. We'll see you next week.